All right, hello, everybody out there in Neisterland. I hope you're enjoying your conference from home. It's really cool that we're able to do this virtually. Thanks to everyone on the Neister board for putting in so much work to make this happen. I really appreciate it. This is a pre-recorded session about frontotemporal dementia. My name is Hannah Brown, and I'm a recreation therapist at the Rochester Psychiatric Center. Prior to working here at RPC, I was an educator for the Alzheimer's Association, and before that, I worked in a senior living facility, and I also worked in a group home for adults with developmental disabilities and dementia-related diseases. So I gave this presentation, I think like 3 years ago at Nystra. So if you went to the presentation then, there's some new updated information with like newer statistics. If you haven't seen it yet, I hope that you get something out of it because FTD is a really challenging disorder to program for. So I think it's really important that we as rec therapists who work with older adults know a little bit about the pathology and some common symptoms that you might see and how to program around that. So also, if I seem a little unsure at any time or, this is like a low effects kind of situation, I am not good with technology, and I'm also not good at pre-recording things I'm learning, contrary to what a lot of my friends and family would think. I don't actually just talk to hear myself talk. It's extremely hard to pre-record something, so shout out to all the teachers, too, who have been doing this throughout the last year, because it's so challenging. You guys are amazing. All right, but back to it. Let's talk about FTD. All right, so frontotemporal dementia, commonly known as FTD, right? It's pretty rare. It only makes up 10 to 20% of dementia-related diagnoses, and it's probably very underdiagnosed. When we think about what it takes to diagnose something as FTD instead of a different dementia-related disease, it's really based off two things. Number one, a brain scan or other biomarkers, which are extremely expensive for people to be able to afford and insurance doesn't always cover, or a lot of testing and a practitioner who's really following up to find out about somebody's symptoms. So of course, those practitioners exist and they're wonderful, but they're not really accessible to a lot of people. So FTD is probably very underdiagnosed. It's neurodegenerative, so that means it affects neurons, and degenerative meaning that those neurons will deteriorate over time. It's progressive, so it does get worse. Something that we see with FTD is a period of plateau, and that's really common, but that plateau doesn't last forever. Eventually, FTD is fatal, and it will always get worse over time. And obviously, FTD affects the frontal and temporal lobes of the brain. So FTD used to commonly be called Pick's disease, which now is its own separate disorder that we're going to talk about. But you might hear it called Pick's disease, sometimes colloquially too, or you'll hear frontotemporal disorders or frontotemporal degeneration. So FTD is all about the brain, right? So we have our lobes of the brain here, color-coded nicely so that we can see them. Obviously, FTD is affecting the frontal and temporal lobe. Other dementia-related diseases are present in other parts of the brain, which we'll talk a little bit about the difference between FTD and Alzheimer's. But obviously, FTD is affecting the frontal and temporal sides on both sides of the brain, except for one specific variety of FTD, which we'll talk about in a little bit. But let's talk more about the frontal lobe. The frontal lobe is wild, right? So the frontal lobe has a lot of cells that produce and regulate our neurotransmitter, dopamine. So we used to think about dopamine as being like a pleasure neurotransmitter, but recent studies have kind of changed the way that scientists and people in the medical profession are looking at dopamine, because now we're kind of seeing that it's encouraging reward-motivated behavior, which obviously is really important for us to know as recreation therapists, because not only are we trying to motivate our participants to be engaged in healthy recreation and leisure, but we're also using recreation and leisure to help motivate our patients to complete other activities of daily living. So that kind of new way of looking at dopamine is pretty important for us. So our frontal lobe is really associated with task completion, motivation, judgment, reasoning, social behavior, attention, planning, executive functioning specifically, and our short-term memory. So short-term memory being those like small amounts of information that are more current in our brain. But what about our temporal lobe? So this consists of structures that are pretty vital for memory, specifically the hippocampus. And the hippocampus is really important for Alzheimer's disease as well. That's where Alzheimer's disease starts. But the hippocampus and the hippocampi structures are in the temporal lobe and are also affected by FTD in different ways. So our temporal lobe also forms our visual memories, right? So that those scenes laid out in our head, those pictures, right? It processes our sensory input, specifically our auditory and visual sensory input, and more specifically, faces and object recognition. It's also important for our language recognition. Our Wernicke's area, our Broca's area, those are areas of our brain that are very important for language comprehension, and those are located in the temporal lobe. It's also important for the creation of new memories, and that's related to a lot of the hippocampi structures. So our frontal and temporal lobes are really important for executive functioning, which is huge for us as RTs when we're talking about more structured, activity-based, task completion, those sorts of therapies. So what is our executive functioning? It's basically our cognitive processes that control our behavior. So, it's our attention control, right? So our focus, how we're able to follow instructions, right? Which is really important for us if we're doing something structured. It's our cognitive inhibition, so our mind's ability to tune out stimuli. So if we're doing, a program in a room that has a lot of chatter, or we're doing a program over music, if we have good cognitive inhibition, then we can focus on the instructions that are being given and not be worried about, or distracted by music and other kind of stimuli. We have our inhibitory control. So that's our ability to suppress impulses. This is like big in our cooking groups, right? It's like our inhibitory control is what allows us to like stir our cookie dough and look at it and think, ooh, that looks so good, and not eat it, which is important when we're cooking at work, right? We have our working memory. So that's what is holding information temporarily. And a good way to kind of like see this in your participants is like by playing cards, right? Are they paying attention to what you've been playing? Are they strategizing about future moves based on what you've been playing? Are they looking to see if you have any cards down, right? We have our cognitive flexibility. So this is kind of thinking about two different concepts simultaneously, right? And I like to kind of pay attention to this during sports specifically. We play a lot of volleyball at my job now. And so I think this is like volleyball is a really good way to see somebody's cognitive flexibility, right? Are they positioning their body in a way that is going to give them access to the ball while also looking at the other side to see where they should be hitting the ball, right? So it's kind of like you're planning two steps at once. Then we have our planning, which is just thinking about the future, right? So if we're asking our participants if they want to go for a walk, are they going to get their coat on their own? If they are, that means that they have checked outside, looked outside, maybe seen the weather on TV, and they're planning for their walk. And we also have our fluid intelligence, right? So this is our ability to reason and problem solve in new situations. So again, like cooking is really good for that. So maybe we're doing a recipe and we see that we don't have garlic powder, we only have garlic salt. Somebody with good fluid intelligence skills would be able to think, okay, I'm putting in this garlic salt. I need to reduce the amount of iodized salt in this recipe. So it's kind of like that thinking on your toes thing. So we talked a little bit about the hippocampus and how that relates to Alzheimer's disease as opposed to FTD. Basically, there are some main differences. One of the biggest ones from a biological standpoint is that there's no presence of amyloid beta plaques in the brains of people with FTD. So in Alzheimer's disease, our two kind of main issues in the brain are from amyloid beta plaque buildup and neurofibrillary tangles. For people with FTD, they don't have that amyloid beta, but they do have protein deposits similar to the neurofibrillary tangles. So we see a presence of tau protein, TDP43 proteins, and FU5 proteins as well. So there's kind of like three main proteins that are building up in the brain. And similar to Alzheimer's disease, when those proteins build up in the brain, they're blocking neuron functioning from happening. So they're blocking those neurotransmitters from messaging each other. They're blocking the ability for cells to share nutrients, and it's causing cellular death in the brain. So similar to Alzheimer's disease, FTD is causing atrophy or cellular death in the brain. Okay, in FTD, it's affecting different regions of the brain. We mentioned earlier that Alzheimer's disease starts in the hippocampus, but FTD is a little bit more widespread because it not only affects the temporal, but the frontal lobes. FTD generally has an earlier onset. It can be as early as age 20, but generally the disease presents itself in people's 40s to 60s. Alzheimer's disease starts being more common in people's late 60s, but that incidence rate increases as people get older as well. FTD also progresses more quickly. Like I mentioned earlier, there's a plateau phase, but generally FTD has a shorter duration than Alzheimer's disease, and so it becomes terminal more quickly. Another main thing that we see is that memory loss is very, very prominent in the early stages of Alzheimer's disease, whereas with FTD, it's more towards the later stages. And that's just because of where these protein deposits are popping up in the brain, causing that cellular death. So this is kind of big because a lot of people tie dementia-related diseases in with memory loss, but with FTD, it's not always the case that people experience memory loss in their earlier middle stages. And so it can cause people to be kind of confused and maybe even doubt a diagnosis of FTD. But we just need to remember that, you know, different parts of the brain have different functioning. And so if FTD is following this different disease progression throughout the brain, it's going to present differently. All right, so here we have our guy, Arnold Pick. So he's the one that discovered FTD. I love this picture because he looks like he just insulted your outfit at a party or something. Like, I'm very curious about what he was like because, I don't know, he looks sassy in this picture. But basically, he was a psychiatrist who was studying the brain around the same time as Alois Alzheimer. I'm also very curious as to if they were friends or if they feuded or what that relationship was like, because they both did really important research about the brain at the same time, which is kind of cool. So we have our Pick bodies. So these are named after Dr. Pick. Obviously, he was the first person to identify them. And basically, these are just these protein buildups that are causing cellular death, and they're kind of presenting in the hippocampi, in the limbic system, and in the subcortical system. So all over the brain. So you see in the middle there, that is a Pick body. It's got that like big, fat kind of wall-looking thing. So what are specific diseases associated with FTD? Because there are a number of different diseases that are kind of under the FTD umbrella. Like we mentioned before, people used to think that they were all one disease, that Pick's disease. But now we've done a little bit more research and we're kind of teasing them out into different diseases. So this is kind of cool if people have the ability to figure out what specific FTD disease the person they're caring for has, because it makes a lot of difference in the interventions that we do with people. Again, it's really hard for people to get diagnoses because it means that they need to have a healthcare provider who's like working very closely with them. But it can really, really improve how we're targeting their FTD. So let's talk about it, right? We talked about our Pick's disease, which used to refer to all FTDs, but is now known to be its own specific disease. And what this is kind of characterized by is atrophy in the frontal and temporal lobes but it completely spares the parietal and occipital lobes. And there's kind of like a different buildup of proteins. They have a different shape and protein composition than our other specific FTDs. So again, it's progressive and degenerative. So we have our FTD with motor neuron disease. You'll kind of see this written out sometimes as FTD/MND, right? So this is an FTD with a higher impact on motor functioning, sometimes referred to as FTD with ALS, ALS being our Lou Gehrig's disease, right? So 30% of people with ALS show frontal lobe degeneration, kind of interesting. So it's a pretty high incidence rate for people that have ALS. Again, it's progressive like all FTDs. But our symptoms are pretty different because they're really centering on people's ability to move, right? So people are experiencing more muscle stiffness, impairment of fine motor skills, atrophy, so cellular death of the muscles, cramping, and twitching. So some other things you might see along with this is maybe some like bowel and bladder dysfunction and some sensory processing issues. So how people are like kind of feeling things on their muscles. So for us as RTs, this is a really important moment for us to collaborate with OT and PT because they have a lot of good insights to share with us on things that we can do to try to maintain somebody's functioning for as long as possible. With all FTDs, we really should be focusing on the health protection as opposed to health promotion model because we are not going to be able to bring somebody's cells back alive in their brain. We're not. But what we can do and what we can be really effective at is trying to maintain their abilities for as long as possible, increase their quality of life, and hopefully manage some of their pain and distress, right? So if we're working with OT-PT, this is a great opportunity for us to collaborate on maintaining that endurance. We also have our behavioral variant FTD. So this is kind of like the FTD that I personally have seen most commonly, working with people with dementia-related diseases. And I'm not sure if that's just because, I'm in mental health right now, or if it's because when I was working for the Alzheimer's Association, the behaviors that people were exhibiting were very challenging and that was causing more families to reach out, or if it's just maybe a more common FTD. But this is the one that is like really challenging for us as healthcare providers, right? So it's FTD with very significant behavioral changes. So we have some difference in the protein deposits on the brain. Again, we're not really going to be able to know that when we're working with somebody unless they've had a brain scan, but it's good information to know. But our symptoms are very significant with behavioral variant FTD, right? So we see a lot of hyperoral behaviors. So that's people, putting objects in their mouth, sucking on things, chewing on things. It's almost like a compulsion. It's kind of similar to how we see children like putting things in their mouth. And obviously, we're working with adults here, so we need to keep that in mind. But it is related to that like kind of compulsive, like impulse control kind of behavior. We're seeing more stereotyped and repetitive behaviors in people. So we might be seeing like rocking, people might be picking at their skin or picking at objects around them. I worked with an individual who used to pull leaves off of a fake plant. He was just kind of repetitive and compulsive about that. We see personal hygiene changes. So somebody might be showering more or less, brushing their teeth more or less. I worked with an individual through the Alzheimer's Association who just wanted to brush his teeth 24 hours a day. Might have been a sensory thing or just kind of stuck in that loop, but we see some changes in that way. We can see hyperactive behaviors in people, so that kind of like rocking, twitching, pacing, inability to focus. We see more hypersexual behaviors with a lot of people. So everybody has a thought now and again that someone else has a nice butt. That's normal. We all think that at some point or another. But we have good impulse control. So we can think in our minds, that's a nice butt. For somebody that has cellular death in their brain that's causing them to struggle with impulse control, they might not have the filter to not say anything or to not touch. So we see a lot more of that kind of hypersexual behavior from people. Impulsivity, again, so like the inability to just control an impulse, right? You see like a piece of food on the floor, somebody's going to pick it up and eat it. They don't have the executive functioning to stop themselves from doing that. We might see more apathy or blunting, so an inability to express emotion effectively, and major mood changes. And that can really go like any way. I've worked with people who were very like cranky at different parts in their life. And then when they got FTD, they really chilled out, became like softer, sweeter. And then on the other hand, I've worked with people who are like, very nice, sweet grandma types. And then all of a sudden they get FTD and they're dropping F-bombs like it's going out of business. So you can see a lot of mood changes in people. So again, like with FTD, we're just seeing a lot of cell loss in areas that control our conduct, judgment, empathy, foresight. And this is a really, really challenging variant of FTD to work with. A lot of the behaviors they can seem like mean or volitional, but we just really have to remind ourselves that what's happening to this person is a biological cellular change in their brain. And as tough as it is, we really have to try to have patience for it. So another type of FTD is our progressive aphasia or progressive non-fluent FTD. So this is an FTD that really affects people's ability to understand or express speech, right? So it's characterized by very profound changes to speech. Behavior and personality are usually not affected till the later stages of this disease. And speech changes originate from the brain, but are not from a stroke. So, when we think about somebody having a stroke, we think about that acronym like FAST, right? And the S in that is for speech, because we're seeing like slurred speech initially, but then other issues related to that. Luckily, brain imaging is pretty good to check on if somebody has a stroke. So that's kind of the progression for this in like diagnosis, is that they'll check and see that somebody hasn't had a stroke. The disease follows a pretty set progression, starting with hesitancy in speech, so like more long pauses, right? And that's from the person trying to process what they're going to say, and then having the ability to move their mouth to be able to say what they want. Eventually, people will be speaking less until they're fully unable to speak at all. So there's kind of like two parts of this, right? Because we're having changes to speech that are coming from the brain. So that's our like aphasia. But then we also see people experience some apraxia, which is like the inability to control their muscles. And so their speech can become more slow and effortful. And then, of course, along with that, we're going to see swallowing issues, more drooling, that kind of thing. So just a little side note, something that I found to be really effective when working with people with progressive aphasia FTD is using music. So music is processed in a lot of different places in the brain, not just the frontal and temporal lobes. It's also coming from the occipital and parietal lobes. So there are parts of the brain that are still able to process lyrics. So something that can be helpful when you're working with somebody is encouraging them to sing what they're saying. And also when you're interacting with them, you can try singing what you're saying as well, because it might just like donk off that right neural pathway that's in the parietal lobe instead of going to an area that might be experiencing atrophy. So something kind of cool to try with people. We have our semantic dementia, right? So this accounts for about 20% of FTD cases, so that's a pretty high number. And it's characterized by language difficulty due to atrophy in only the left temporal lobe. So we have two temporal lobes, right, on either side of our brain, just like we have two temples. So semantic dementia is affecting only the left temporal lobe. Something that's really common with semantic dementia is anomia, which means that they're forgetting the right the right word, right? So anomia is a pretty common symptom in a lot of other dementia-related diseases, but we see it a lot in semantic dementia. So eventually they're forgetting the word, but then the whole concept of the word can be lost. I've never actually seen this, but I found this in some research that some people preserve their ability to use numbers and colors, which is kind of cool. So I'd be interested to hear if anyone has experienced that. People have still generally have their ability to have their memory, working memory, and orientation, and their behavior isn't quite as impacted. So that's kind of interesting too. But people have a lot of difficulty in facial recognition and reading emotion to the point where it might seem like somebody has a memory issue. I worked with somebody through the Alzheimer's Association who, their family really thought they had a memory issue because every time they would see their wife, they would not recognize their wife's face until their wife was able to orient them, by prompting and saying who she was. Reading emotion is really, really big too. That's a huge part of how we communicate, right? Is through our nonverbal communication. So if people have a hard time with facial recognition and seeing expressions, that can be a really big challenge for people. And it generally has a shorter duration than other types of FTD. Generally, the duration is about 6 years for people until the disease ends up becoming deadly to them. So we have progressive supranuclear palsy, right? So when we think about the word palsy, right, we're thinking about weakness. So this disease causes weakness, right? It damages parts of the brain above neuron clusters, particularly controlling eye movement. And so the big kind of hallmark characteristic that you're going to see with this type of FTD is that people have a really hard time and eventually an inability to aim and move their eyes to track objects. It's very rare, and it used to be considered a Parkinsonian disease probably because of that that kind of like eye twitching, eye movement thing. So some other symptoms that we might see are a loss of balance, right? Stiffness and gait changes, and some mood and personality changes. So our common symptoms of FTD, right, are personality changes. These are so big and so challenging. For caregivers who have a loved one that has FTD, it can be extremely challenging to see those personality changes, and it can cause a lot of anticipatory grief. It's really hard. I mean, people just lose their loved one while they're still alive. For us as RTs, it can be really challenging too, because having somebody with FTD on your caseload can be a full-time job in and of itself. They're very challenging. FTD can cause difficulty in language and thinking. We've been talking a lot about that, right? Anxiety and irrational fears. So when I think about anxiety, I think about it kind of as being very chemical, because I'm kind of thinking of it from like more of a mental health perspective. But, there's also a component with FTD too, where people have moments of clarity, where like they're having a thought and it kind of hits that right neural pathway where there isn't a lot of cellular damage, and they can become kind of aware that something is wrong with them. You see that a lot. One guy that I worked with, he would just kind of have moments where he would get quiet for a second and stare off, and he would just say, "I'm so far gone. I'm so far gone. My mind. I'm so far gone." So people, even though they can seem unaware, especially when they're having those behavioral changes that cause lack of empathy, they can seem very unaware, but, they can often have moments where they know that something is wrong, and that can be really upsetting and cause a lot of anxiety for people. So, when somebody with FTD is being challenging, just try to remember too that it's very challenging and scary for them. People can disassociate from their family for a number of reasons, right? Number one, they might be having those moments where they know that something is wrong, and there's a lot of guilt and shame involved with that. But families can disassociate from people with FTD as well. FTD can motivate a lot of really challenging and upsetting behavior, and that can cause a lot of problems with family dynamics, and it can also potentially lead to somebody with FTD victimizing somebody else. So you will see that sometimes, like people having that disassociation. people have impaired social conduct, right? So our frontal lobe is everything for our ability to function with other people. It's our ability to have empathy, to think about others, to say and do the right things around them. So when we're having cellular death in those areas of the brain, we see changes in social conduct that have a big impact on how people with FTD relate to others. Again, that impulsivity might be grabbing something, putting it in their mouth. It might be breaking something, right? It might be groping. We all have those flickering thoughts. That's very normal, but we have impulse control. And that passivity and low motivation versus the inertia and overactivity, right? So we can see the that kind of slow checking out that people experience, but we can also see more of the hyper kind of behaviors of pacing. FTD also doesn't always affect people's bodies, right? We talked about the palsy related FTD, but with other types of FTD and specifically the behavioral variant, a lot of the time people's physical functioning is preserved. So somebody, could be in their 40s, 50s, 60s and very physically healthy, but have FTD. They're still going to have the same physical needs as somebody without FTD. They need to exercise. They need to move, right? They are still going to have the same emotional needs. They need to feel loved. They need to feel wanted. They need to feel, productive, like they're doing something. Those needs still exist in people with FTD. And it's up to us to figure out ways that we can provide opportunities for them to engage meaningfully despite the changes that are happening in their brain. So what about our therapeutic considerations as RTs? For somebody with FTD, we need to think safety first, always. Chances are, if you've worked with somebody with FTD, you probably have some kind of horror story already about them hurting themselves or someone else. It's really, really challenging. We need to be really careful, again, that they're not hurting themselves and they're not victimizing somebody else, right? So how we're going to do that? We're going to provide constant redirection. Very challenging, but very important. We're going to just kind of be always having our eye on a person with FTD. We really want to limit materials to non-toxic items, right? Because we talked about how people are experiencing those hyperoral behaviors, and that can mean that kinetic sand that you're working with looks delicious to them, right? Making sure our paints are non-toxic, right? Making sure that if we're doing any kind of cooking program, if we're going to be using foods that are not safe to be eaten raw, that we're hand over hand, and that this is somebody who hasn't demonstrated that very impulsive hyperoral behavior. We just want to be really careful. We might want to use larger game pieces, and that can be really helpful, especially as people have more impacted movement ability. They're going to have issues with their fine motor skills likely as well. We might want to remove exposure to children, okay? Not for every person with FTD across the board, but something to consider, right? If somebody is experiencing a lot of hypersexual behaviors or violent behaviors, it might not be safe for them to be around children, okay? So we're going to always be providing that close supervision. We might need to redirect people from begging. This is a pretty common one. People that have FTD can get kind of caught up in wanting money or food. And so we want to be around to just kind of give them like a friendly redirection, right? To discourage that from happening. We want to maintain a friendly expression. People are having a hard time reading nonverbal cues. They're having a hard time recognizing faces. They're having a hard time interpreting expressions. We really, really, really want to try to maintain a calm, even way of speaking and a very friendly expression. And it can be really, really challenging. I have gone into the recreation closet at work, at both, recreation-oriented jobs that I've had, and cried many, many, many times because sometimes you just need to have a break. If you need to go to the bathroom and fix your face, and that's going to be what allows you to continue working with that person and keep an even keel, then do that for yourself, right? Because if you start to get irritated and stressed out, people are going to feel that around you, and that's going to turn into a negative feedback loop. It's very easy to tell what people can maintain their cool around people with dementia-related diseases and who can't, because when people who maintain their cool walk into the room, people with dementia will smile. People might not always remember what you said, but they almost always remember how you made them feel. So be conscientious of that, right? You might want to monitor people around less assertive peers. And again, that's just to make sure that somebody with FTD doesn't victimize somebody else. We don't want, anyone to get hit. We don't want anyone to be groped. We don't want any of that happening, right? We don't want people being stolen from. And ultimately, this stuff falls onto us as staff and caregivers. Again, we can't expect somebody with FTD to suddenly grow more neurons in their brain. It's not a realistic expectation that we're going to be able to completely change people's behavior. What we can do is change the environment and change how we are monitoring and interacting with that person. So we need to be conscientious about monitoring people with FTD around their less assertive peers. And we want to utilize positive reinforcement and short-term reward systems, okay? Behavioral interventions are not going to work on somebody with FTD. They're just not. They don't have the executive functioning ability to be able to plan ahead and to think, hey, if I don't steal this thing, I'm going to get a treat later. It's not realistic to think that. They're having atrophy in their brain. So if we're using any kind of reward system, it has to be really short term. And that's going to, mean different things for different people, because people have different levels of functioning at different points in their disease progression. But we want to be really conscientious that we're setting people up for success, because if people are feeling good, they're going to be acting good, right? So we want to really make sure that we're making goals realistic and attainable so that we're not frustrating the person that we're working with and ourselves. All right, so our environmental considerations. So again, we talked about how when we're working with people with FTD, we need to be really conscientious about our own interventions. For frontotemporal dementia, there's really not meaningful medication interventions. We can treat symptoms of the FTD and we can try to make somebody more comfortable, but again, there's nothing that we can do that will stop their disease progression. So what can we do? Well, we can change our interventions and we can change the environment, right? So environmental considerations are super important for people with FTD. We want to provide programming in a less stimulating environment. We know that people who have issues with executive functioning need to be able to concentrate easily on the person who's giving them instructions or engaging with them, right? So, regardless of our setting, things can get pretty chaotic in the rec room, right? Whether we're working in a senior living facility, a school, an adult day hab, whatever. It could be raucous. We're the party people. So we want to just be conscientious that, when we're giving something with more instructions or when we are, really needing our participants with FTD to listen to us, we're making the environment less stimulating. We want to simplify instructions. Be conscientious about the language that you're using, right? If you're offering choices and offering two choices is too hard for somebody, offer one choice. You're still giving them the ability to say no if they don't want to, right? If they're having a hard time interpreting written words, provide some pictures for them. Also a side note too, you might want to laminate pictures if you're using them, because people can drool a lot with FTD. Be willing to repeat instructions. Just be willing to repeat yourself in different phrasing if necessary, in a different volume, with a different manner of speech. We have to be very patient with people. When food or eating is included in programming, consider moving the individual away from the group or providing one-to-one supervision, right? Nobody wants to get their ice cream snatched. It's so sad. It's sad to see. It's just, please, protect other people's snacks. If we have garbage around, we're going to want to secure that. Can the garbage container be in a staff-only area if it has to be out where other patients are? Is there a way that we can put a locking mechanism on it? Because the garbage is full of a lot of tasty and delicious treats. And we want to set people with FTD up for success, not for failure. And so that means taking away their ability to get those tasty treats out of the garbage. We might want to label the individual seat. This is going to help them kind of be less confused, more oriented to where they are, right? So let's talk about some case studies, some specific people, right? So our first person is John. I worked with John. He was in his 70s. Prior to his hospitalization, he had a very high-paying, kind of powerful, prestigious job in the STEM field. He was also a professor. He was married and he had children, but he was also divorced. He had a long history of using alcohol and benzodiazepines, and he also had multiple felonies for drunk driving, starting in his 40s. He also had co-occurring diagnoses of anxiety, depression, and dependent personality disorder. So when I worked with John, he was just kind of a curmudgeon. He would sit in the living room. He didn't want to participate in anything. He was very passive. He had a lot of blunting, right? He had a lot of irritability. He was incontinent of stool very often. And he also refused to eat. He was very, very thin. He had these self-imposed dietary restrictions that weren't really rooted in any actual allergies or intolerances, but he would report having that he couldn't eat dairy or et cetera, et cetera. He also would inaccurately report information to his family. Like he would say that we weren't feeding him or, that we were treating him poorly. He also was non-compliant with medications, right? So his big thing too is that he would kind of ask these perseverative questions like, who's going to give me a shower? Who's working tonight? Who's working tonight? Who's working tonight? And he really wanted a lot of reassurance. He didn't like to go out. He didn't like to participate in activities. And yeah, he was very frequently incontinent of urine and stool. He needed a lot of assistance with that. So he was very challenging, obviously, for recreation interventions because he would outright refuse most things, or if he wasn't refusing, he would actively be trying to stop a program from happening. So he would get up and turn the TV off. That was kind of his big thing, right? So how I kind of worked around him was just very passively finding out what he liked. So I did a pretty big chart review and talked to his former recreation therapist and was able to find some information on him about some things that he liked. One of those things was journaling. So, it was challenging, but I would prompt him often to journal and occasionally would have success with that. Another thing was that I would try to do some passive programming kind of around him. So he liked to sit in the living room. He wouldn't go into the recreation room for programming. So when it was appropriate and possible, I would try to do recreation programming in the living room so that he was kind of passively participating. If he had an instance where he was turning the TV off, we would kind of just make a little bit of a joke about it. Maybe when he was standing up, moving towards the TV, I would kind of dance with him a little bit, and he would chuckle a little bit at that, and it would distract him enough sometimes where if he didn't turn the TV off, then it would kind of redirect, and I would be able to turn the TV on right after he sat down. Another thing that I found was that he really liked the song Elusive Butterfly of Love by Bob Lind. So anytime we were doing any kind of musical programming, I would throw that in there for him. So those were some kind of more passive ways to try to get him engaged. So another case study person that I've worked with is Jim, right? So Jim is a man in his 60s. He's very physically capable still, healthy. He had a history of frequent psychiatric hospitalizations starting in the 80s, and he reports that he used to party a lot. He lived in a van, actually, and would travel around and see the Allman Brothers. But he had no history of MICA interventions, and he was unmarried for his whole life and had no children. So how he wound up hospitalized was he had an attempted rape charge from a senior living facility. And when he got to the hospital, his big thing was that he would masturbate often in the milieu. And that was really challenging, obviously, because he would just masturbate in areas that were out in the open around other patients. He also had a number of incidents of groping peers. He exhibited a lot of stealing behaviors, and sometimes that was like money or jewelry. Other times it didn't really seem to make a lot of sense. So he was the individual that I referred to earlier who would pull the flower or the leaves off of a fake plant in the living room. He also really liked to hoard pens and crayons, so he would kind of just like be around them. He would grab them, put them in his pocket, and then he would just put them in his room and forget about them. He would also steal food from people or eat out of the garbage. I remember one time I brought him out into like a kind of a cafeteria area, and there was like a chip on the floor, and I looked at him and I was like, Jim, like, don't eat the chip. And he was like, I'm not going to do it. And I was like, all right, good. Like, you can do this. Don't eat the chip. And then as soon as I turned my head, he grabbed the chip and ate it. And really, that's a great example of where I need to grow as an RT, because I knew all this stuff about FTD. I knew all this stuff about cellular changes in the brain, and I still had this unrealistic expectation that he was going to somehow magically not eat the chip. And that was just stupid on my part, really. He had a really hard time maintaining attention to programs, so he would often like get up and leave after 5 minutes, and then sometimes he would come back and he would sit down. So what did I do for him as an RT, right? I was very lucky to be able to work pretty extensively with Jim. So we had a twice weekly one-to-one that we would, for about an hour, we would leave the unit. And that was so wonderful because he was so much more calm when he was able to leave the milieu. When he wasn't around people making a lot of noise, where there wasn't a lot of food floating around, where there wasn't a lot of, other activity happening, he was much more calm and easier to engage with, right? So he loved engaging in games. He actually was like amazing at pool. And I think that really speaks to like how people's physical abilities can be preserved with this disease. So he used to whoop me in pool. I only beat him one time in our like maybe 3 years working together. It's pretty impressive. Or sad, I guess, for me, depending on how you're looking at it. He also really liked to listen to music. So that was a big part of our session. He has a favorite radio station. He would put it on. It was like a classic rock thing. He would jam out. And then it would offer us an ability to reminisce over that as well. So he would tell me stories from his youth. That's how I learned about the van. He would talk about, past girlfriends he had and if it was like their song. He also really liked walking, and that was great for him because, like I've mentioned, his physical capabilities were still preserved, and walking was a really good way for him to burn off steam, maintain his endurance, and just stay fit and healthy. And another kind of unintended good outcome from this intervention was that it provided staff with a break because the direct care staff were just very challenged by him, and having him off the unit for that amount of time was really helpful for them. Some other things that we did was just providing one-to-one supervision for special events. So if there was any kind of like, party or picnic or music thing, we would just make sure that there was one staff person who was assigned specifically to him. We would use physical movement as redirection. So that might mean like we were moving rooms if he needed redirection, or dancing, or, getting him involved with some kind of like thing where he's throwing a ball. It just really helped him to kind of drop what he was doing that might have been like a challenging behavior and move on to something else without having like a lot of issue related to that transition. And then we were providing some spatial modification to games. So this is another example of how I still have a ways to grow in my RT practice. I used to play rummy with him very frequently, like maybe once a week we'd play rummy. And he never won, and I always thought that was really interesting because he seemed so attuned to the game. But he would win when he was dealing. That's what I started noticing. So then I noticed that when he was dealing, he was the one that was setting up the discard pile, and it was faced towards him. So he was having a really hard time tracking the discard pile if it was faced towards me. So once we started changing the rummy game so that he could more easily see the discard pile and pick up from it, he started beating me more consistently. So we just need to be kind of more aware of those spatial modifications when we're working with people.